Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with Base Hospital. Thank you for joining us for yet another webinar presentation. Today we have a presentation on hypothermia. Don't get left out in the cold. Presenting today we have Dr. Matt Davis, who's the Interim Medical Director for Education with SWORBHP, and we have Dr. Ryan Arbeau, PGY5 in Emergency Medicine. If for whatever reason this is the first time you've joined us for a webinar, you'll see a PowerPoint presentation and you'll see a control panel. On that control panel, in the bottom sort of two-thirds section down, you'll see a question box. So if you have any questions or if the sound quality is not coming through properly, shoot me a message there in the question box and I can respond to you in the background throughout the presentation. If you have any questions about the PowerPoint itself or anything that comes up in terms of medical directive, absolutely throw those questions in there as well. At the end of the presentation, I'll give you guys the opportunity to raise your hand and ask any questions live if you happen to have a microphone. So you'll see in the top left-hand corner of your control panel a hand icon. At the end of the presentation, if you click on that hand icon, I will be able to see that you've raised your hand and that you have a question that you can ask live. So at that point, I have the opportunity to unmute you and you can ask that question live. And so without further ado, I will pass the presentation over to Matt and Ryan.
Thank you, Stephanie. Matt Davis here. I'm joined here today with Ryan Arbeau. He's one of the fifth-year residents of the Emergency Medicine program down at London, Ontario Health Sciences Centre. And today, Ryan is going to be talking about hypothermia. Welcome, Ryan.
Thank you, Matt. So, we've got a few things to go over here today. We're going to go over some of the pathophysiology. We're going to go over the protocols, what we do in the emergency department, all that kind of stuff. So again, any questions, let us know. So things that we're going to go over here, what the definition of hypothermia is, again, pathophysiology, some predisposing factors, traumatic factors, clinical features, presenting signs, your medical directives, what we're going to do in the emerge management, bottom lines, what we're going to do for hypothermia, and a little bit on frostbite just to throw it in there. So I started working on this a few weeks ago, and we're having the -20 weather. It's kind of ironic that it's +4 and a beautiful day out there today, but we'll do what we can here. So I believe this is Matt Davis a few weeks ago when he was in Utah on his ski trip. I believe we're going to do our first poll question now.
So we'll give you guys just a couple more seconds to answer. And here are your answers. 96% of you chose continue CPR and transport. So I'll pass it back over to Matt and Ryan.
Okay. So the correct answer for that was continue CPR and transport. We'll get in a bit more into that with the protocols and the rationale behind that a little bit later. So continue on with the presentation. So just a definition of hypothermia. Hypothermia is defined as a core temperature less than 35 degrees Celsius. There's a lot of contributing factors. Obviously, exposure is likely the #1 factor. But age, younger people, the extremes of age, very young, very old, are more at risk for hypothermia. Their general health, any comorbidities would put them more at risk. The nutritional status, anyone that's undernourished would definitely be at more risk. Medications that may predispose them, such as thyroid medication, cardiac medication, and any intoxicants, such as alcohol, which would further the hypothermia and put them more at risk just because they're going to be potentially out in the cold longer. So further definition breaks it down by temperature. So mild hypothermia is defined as 33 to 35 degrees Celsius, moderate 29 to 32, severe 22 to 28, and profound is less than 22. And I'd say that is quite profound. Interestingly, as looking at some history, the lowest recorded survivable temperature was 13.7 degrees Celsius. That was actually, I think it was a Norwegian radiologist who that was, and had only mild residual symptoms after her recovery. That's a little bit of history there. A little bit of the boring pathophysiology. So everyone has their basal heat production that has various things that cause that to change: food ingestion, muscular activity, for fever, cold exposure, all of these things. Cold stress by itself increases your muscle tone, which increases your heat production. It may increase by as much as double, but this only lasts a few hours due to muscle fatigue. Further, with the increased muscle tone, shivering increases your oxygen consumption, which also contributes to muscular fatigue. Heat is lost through 5 basic mechanisms, which I won't go into detail for all of these, but radiation, conduction, so skin-to-skin contact, convection, evaporation, and respiration. So just basic, your breathing, going to be losing heat. So looking at some of the system by system features of hypothermia, with the cardiovascular system, you're going to have an initial tachycardia, which is followed by a progressive bradycardia. The EKG features of hypothermia are actually quite unique and interesting. So you have something called an Osborne J wave. That's seen at the QRS-ST segment junction. This is diagnostic of hypothermia, but is not prognostic. If you have the J waves, doesn't mean you're going to do better or worse than anyone else. Usually you have to be less than 32 degrees for those to appear, and it does actually appear as a STEMI. So looking at this cardiogram, you can see in V2, 3, and 4, and in the blown up slide or picture to the left, you get the Osborne J wave there, and you can see that it actually does look like it could be an ST elevation. But waking up a cardiologist at 3 in the morning for someone with a temperature of 25 probably won't go over too well, I would think. So, furthermore, basically any atrial and ventricular dysrhythmias are common or possible in moderate or severe hypothermia. The reason for that is all of your intervals prolong, and the PR, QRS, and the QT all prolong in that order. So any of these dysrhythmias are likely or probable. VFib is the most common rhythm. And looking at VFib asystole, it is multifactorial. So things like hypoxia will contribute. The more the patient is moved, that can contribute as well. Acid-base disturbances, patients are going to be acidotic, and they're going to have autonomic dysfunction. They're going to have problems regulating their temperature, blood pressure, all of those things. So all of those factor into any of these bad rhythms appearing. Something else with the under the cardiovascular system is you can have a core temperature after drop. So once they're out of the cold in the emergency department and you're rewarming them, your temperature can actually go down further, and this is because you have a countercooling of the blood due to a perfusion of cold tissue. So all the blood is getting shunted centrally, and now you're rewarming, blood's going out to the limbs that are very cold and frozen, and that the blood's getting cooled, coming back, and your temperature is dropping. So that's just something that we need to pay attention to, and they're not necessarily getting worse because of this. That's just a normal result of your rewarming. CNS-wise, as you might expect, you're going to have a decreased level of consciousness. Interestingly, brain waves on an EEG decrease as the temperature drops, and below 19 or 20, the EEG is actually silent, which I thought was kind of interesting because people can survive As I already stated, if temperature is lower than that. Blood flow is temporarily shunted to the brain in hypothermia, but this is not enough to maintain consciousness as the temperature drops further. Furthermore, the renal blood flow is decreased by about 50% at 27 to 30 degrees, so you can go into acute kidney injury. The kidneys also excrete a large amount of deadly urine. This is the cold diuresis, which I'm sure everyone's experienced to one extreme or another. Severe hypothermia also causes relative hypervolemia because of peripheral vasoconstriction as well, and the cold diuresis is thought to be a volume regulator to diminish this. So your blood is getting shunted centrally because of peripheral vasoconstriction, so your body thinks that it's hypervolemic, so then that's thought to be part of the diuresis that occurs. Respiratory-wise, initially the hypothermia stimulates your respiratory drive and your respirate does increase, but this is followed by a progressive decrease in your minute volume and your respirate. Just some numbers here. So your CO2 production decreases 50% with an 8-degree decrease in temperature. And other factors such as bronchuria, fluid forming in the lungs, your decreased ciliary motility in the lungs, and you can have non-cardiogenic pulmonary edema, and this all further impairs respiration. Predisposing factors included decreased heat production, increased heat loss, impaired thermoregulation, and miscellaneous. These are all the broad categories. This is a shot of our emergency medicine textbook, Rosen's, which further breaks these down to there's a lot of factors that predispose you for hypothermia, which I won't go into all of them, but you can have decreased heat production if you're hypothyroid, if you're diabetic, hypopituitary, like I mentioned earlier, age extremes, increased heat loss, pharmacologic problems, burns, cold infusions, heat stroke treatment, all these things, impaired thermoregulation. If you have a neuropathy, again, diabetes falls under that, any CNS trauma or a stroke. And miscellaneous, so if that's recurrent hypothermia, sepsis, you can be hypothermic with that, pancreatitis, etc. So I won't go into all of these, but just to let you know, there's a lot of factors.
So that's quite the list there, Ryan, and I'm sure you've got this little quiz coming up at the end of your 5th year of residency, and you put that into memory, right?
I absolutely have, yeah. I hope there's a quiz at the end of this so I can regurgitate it. Not really. Hypotension and hypovolemia also contribute to hypothermia. And if you are hypothermic, likely you are going to be hypotensive from your decreased cardiac output and your relative hypovolemia because of your cold diuresis. So this is kind of a vicious cycle that occurs. Other things, so blood loss may be worsened due to a number of reasons. Because your coagulation cascade, all your clotting factors, aren't working as well, and your fibrinolysis, your clot breakdown activity, actually increases with hypothermia. So your clotting factors aren't working as well, your factors of breakdown clots are increased, so bleeding is increased, and platelets could also be sequestered and not work as well either, so your clotting is further diminished. So when the exposure is obvious, the diagnosis is simple. If they're in the snowbank and their temperature is 25, you know what's going on. However, when you don't know what happened, there's vague symptoms, so nauseous, chills, short of breath, or confused, or a little bit dizzy. Paradoxical undressing is actually something that's talked about in the literature. So they're cold, but they want to take their clothes off. It's not
because they're at a party.
It might be because they're at a party, but that's not the only reason. So often associated with intoxication, which I'm sure everyone knows why. If someone's high or drunk, then they're not feeling the cold, so they're going to stay out in the cold or long. Any underlying illnesses, psychiatric emergencies, so during acute psychotic crisis, or they're a victim of a trauma and they just can't get inside, a ski accident or they crash the vehicle, etc. Again, this is another huge list that I have to have committed to memory for my quiz in a few months, but the presenting signs of hypothermia by system, and there's a ton of these. So you can have flushing of the face, facial edema, all of these things, so tachycardia. A lot of this we've already gone into, so I won't go into this any further. Now this is a screenshot of the paramedic directives for hypothermic cardiac arrest. So looking at this, we have conditions. CPR we need to do on all of these patients, and defibrillation is going to be based on if they're in VF or VT. And we'll go to the next slide here. So if it is a shockable rhythm, the protocol is one shock and then you transfer. And asystole is just CPR and transfer. There's no epi that we're going to use. We'll get into that a little bit more a little bit later. So we'll go on for that. And so the reason why one shock is all that's advised is because defibrillation attempts are usually unsuccessful until the patient's at least 28 to 30 degrees. Active rewarming is the primary treatment, but I need to stress that this isn't something that should be done in the field. This is something that needs to be done in the emergency department. So that's why we don't go and continue doing shocks and epi in the field. So just some more things in the emergency department. So looking through blood work, a normal white blood cell count doesn't mean that there wasn't an infection going on, so you may want to consider giving antibiotics. Again, referring to the platelets, they may be artificially low because they're being sequestered in the spleen of the liver. You may have problems with your potassium. It's increased with the metabolic acidosis, rhabdo if your muscles are breaking down, or renal failure. All these things can raise your potassium, so these are all things that we need to pay attention to. Glucose is initially elevated due to the stress response, but then all of your glycogen stores become depleted, so hypoglycemia may occur. So hypoglycemia may be something that you have to treat as well. Interestingly, ischemic pancreatitis is something that's quite common with hypothermia, so in the emergency department we should draw pancreatic enzymes to evaluate for that. And your creatinine kinase, your CK levels, can help establish the degree of rhabdo. Again, referring to the coagulation in hypothermia, your clotting times are going to be increased, your platelets are going to be decreased, and your blood viscosity is going to be increased. You're going to have thicker blood, increased risk of thrombosis formation. So all of these things are coagulation concerns that we have. So management. Patients who are cold, stiff, cyanotic, fixed pupils, inaudible heart sounds, and no visible chest wall movement should be resuscitated. I know all that sounds kind of counterintuitive, but if they're hypothermic in a snowbank, you don't know whether that's just because of the hypothermia or if they are actually deceased at this point. So you want to try and prevent further heat loss, so get them warmed up. And the goals of pre-hospital care is to rescue, examine, insulate, and gently transport. As I mentioned earlier in the cardiovascular section that dysrhythmias are increased by a lot of movement, so they should try to be moved as gently as possible and try to insulate them, get some blankets on, and just get them out of the situation. If they're unresponsive and they're not shivering, you have to presume that they're hypothermic. Standard oral thermometers record only the 35 degrees, so rectal thermometer, or rectal temperature I should say, should be obtained, but you guys don't have to worry about that. We'll do that in the emergency department. Other things we may do, a Doppler may be needed to determine if the patient has a pulse, blood pressure, if the limbs are ischemic. may need to intubate the patient for airway protection, and all patients should have cardiac monitoring, likely with advanced monitoring, such as an arterial line and central line for central venous pressures. All these patients should be volume resuscitated. As I mentioned, they are hypovolemic due to their diuresis, and warm normal saline should be administered. So do that in the emerge. So heat the saline to 40, 42 degrees and administer that. You can do that through the rapid infuser or just through large bore IVs. Blood flow during CPR is greatly reduced in hypothermic patients. This is due to decreased chest wall elasticity and decreased lung compliance. So the heart actually acts as kind of a passive conduit in hypothermia. So the blood kind of passes right through. The mitral valve remains open, and blood continues to circulate in the left side of the heart. Tissue decomposition, rigor mortis, and fixed eyelid pupils are not always reliable criteria to withhold CPR in hypothermic patients. That's something you have to consider in the field. What about medications? Most, likely all medication effects are decreased with hypothermia. This is decreased metabolism, decreased blood flow to different parts of the body. There are newer animal studies that actually show that vasopressors increase the rate of ROSC when compared to placebo. So the current AHA guidelines referring to those animal investigations say that it may be reasonable to consider administration of vasopressor during cardiac arrest according to the standard ACLS algorithm concurrent with rewarming strategies. And I think that's the most important part, that it's concurrent with rewarming strategies. These medications can be dysrhythmogenic on their own, but if they're not being warmed, it's likely not going to work. So that's why the protocol says just the shocking for VFib and transfer. And when they get to the emerge and they're being rewarmed concurrently, then we'd be giving them the epi along with it. So I already mentioned that, but the epinephrine, you do not administer that on scene because the primary treatment is active rewarming. So a rapid scene time and early transport is the goal of the pre-hospital treatment.
And that's going to be the biggest thing for these patients is they need to be rewarmed. So getting them to the emergency department where we can actually institute the active rewarming is key to these patients' survival.
All right, so
a question that that we got from the ASMAC around May 25th, 2012. Well, the AHA guidelines do mention, we maybe should be giving vasopressors. There's not a lot of evidence out there, and the question has become, well, should I be giving epinephrine during these arrests? And the answer to that is, like I said, the most important thing is getting these patients to the hospital where they can be actively rewarmed. So we want you to minimize the scene time, hence why we have the protocol which states one shock and transport, or if it's asystole in these VSA patients, then just do CPR and transport to the hospital. It's going to be a challenging situation in the back of the ambulance. If you are able to get an IV started and give epinephrine, then that's absolutely okay. It's not expected that you do this, but if you are in the ambulance and you are able to do it, then by all means go ahead, but you will not be faulted if you cannot give epinephrine during these situations.
Okay, so further with that, so any vasopressors other than epi, this is referring to recess medications like dopamine, should be avoided if possible because of the dysrhythmogenic potential of having minimal effect on the peripheral vasculature because it's also vasoconstricted. But that being said, if necessary, you can use low-dose dopamine. This is, again, in the emergency department. And furthermore, again, VFib should be defibrillated, but if unsuccessful the first time, rewarming should be performed. That being said, practically speaking, in the emerge, we are going to be doing standard ACLS protocol, 2-minute rhythm checks, shocking epi every 3 to 5 minutes while we're rewarming them. We're just not going to stick the warm IV fluid in, put the bear hugger on them, walk away, and then check them in half an hour. We're going to be doing all of those things concurrently. With respect to rewarming, two ways you can do that. It's passive external rewarming, but the patient must be able to generate heat. Active rewarming, a few things you can do. External, you can do hot water bottles, the bear hugger. Active core rewarming, airway, you can give humidified oxygen in the T-tube. Peritoneal dialysis is something else that is listed in the active core rewarming. Heated IV fluids, you can actually instill warm IV fluids into a chest tube or a Foley catheter. Dialysis is another option for rewarming, and cardiopulmonary bypass is listed on the options for core rewarming. So the bottom lines for these hypothermic patients: if they're hypothermic and a shockable rhythm, shock once and transfer. CPR as usual. Active rewarming is the primary treatment, and short scene time and early transportation is the goal of therapy in hypothermic patients. So I believe we have another poll question now.
Okay, so I've launched the question very similar to the first one. Pay attention to the one difference, though. You have 54-year-old male found again in the snowbank. GCS3, he's cold, cyanotic, rigid, pulseless, and in V-fib this time. What should you do? Should you continue CPR and transport, defibrillate once, CPR, and then transport, complete 3 more analyses, and patch for a tour if no ROSC at that point? I'll give you guys a few more seconds to answer that. And we have 100% of you who have chosen to defibrillate once, CPR, and transport. Well done.
All right, sounds like everyone's paying attention, so I'm glad. Just a few more things at the end. I'm just going to throw in some information on frostbite. So there's kind of a continuum of frostbite. So it starts out as frost nip, which is a superficial cold insult. It's numbness, tingling, you rewarm the patient of the limb and it goes away. There's frostbite, which is tissue injury, destruction with prolonged cold exposure. Something else called chilblains, which is a mild cold injury following repetitive cold injury, so people going in and out of the cold. And then there's trench foot, which was first described in the First World War. Prolonged exposure to wet cold at temperatures above freezing. So with frostbite, you have a freezing injury cascade. You have a pre-thaw phase, which is tissue cooling, increased blood viscosity. You have a freeze-thaw phase, which you have ice crystals that actually form in the tissues. Then you have vascular stasis, progressive ischemia, and then you have coagulation because the blood's not flowing, and tissue breakdown. So we have some nice pictures of the continuum here on the side. Field rewarming is rarely, if ever, practical, but affected areas should have the wet clothing removed, be insulated, immobilized, and the patient transported.
So we have a question that has come in from one of the audience members here. It's regarding the practicality of using warm fluids in the field.
So it's Mike Llewell here, one of the medical directors, and looking at the question, it talks about, speaking of predisposing factors, what's the role of warmed fluids pre-hospital? The question actually references not just hypothermia, but also references penetrating trauma as well. Clearly, the role of pre-hospital fluids in penetrating trauma is a bit different in terms of physiology than in hypothermia. We also have reduced the amount of saline we think is appropriate with regard to the new ATLS guidelines for penetrating trauma, as well as for blunt trauma, looking at shifting more towards colloids and blood as an earlier fluid choice. And you're going to see some changes that come across in some of the new guidelines in the next coming years. But speaking specifically with regard to hypothermia, the role of pre-hospital fluids and rewarm specifically, it's actually not a good method of actual active core rewarming. It actually prevents further heat loss, but it's not actually a good way to warm you up. You actually need, if you're severely hypothermic, active core rewarming, and that's the reason for the early transport. The other issue is that fluid rewarmers are expensive and actually don't exist in the truck. So getting amount of fluid in, and a substantial amount of fluid enough in, actually can actively warm you up, would require huge volumes, and that's going to dilute your clotting factors even further. So one option, yes, we don't really have it in the field. It's not part of the ambulance equipment standards. If there were warmers on each truck, then sure, it would be a strategy, but those don't exist today.
Thank you, Dr. Luell. A couple more questions here. One question that came in was, if we have time to get a blood sugar and it does not delay transport, is that a go? If their GCS is less than 15 and it's not going to delay sleep time, absolutely get a glucose on them. Again, when you have the VSA patient, is a glucose going to help you on that patient? Not like this is not a hypoglycemic arrest when they're found in a snowbank. This is because they are hypothermic and need to be rewarmed. Another question came in regarding intubation in these patients, and the question was, considering that a large amount of heat is lost through the airway, should these VSA hypothermic patients be intubated as a priority? That's a very good question. Actually, intubating the patient isn't going to reduce any heat loss for the area, for the patient. In the emergency department, what we'll actually be doing is giving them heated, humidified oxygen. So that's where they do get some of their warmth returned to them from, is through intubating the patient. And as we all know, that intubating patients, that's not the save-all for these VSA patients. The most important thing is CPR, and again, early transport for these patients.
Great. Thank you, Dr. Davis and Dr. Luell. So just to finish up here with frostbite. So again, in the pre-thaw, you should assess the pulses in that limb, protect the area, splint it if need be. If they have any problems, you want to stabilize the core temperature, but again, that's going to be something more in the emergency department, and address any other medical concerns that may be going on with the patient. In the emerge, so to thaw the limb, we try to immerse the part in circulating water at 37 to 40 degrees Celsius. We provide them with analgesia during that time. Post-thaw, we want to dry and elevate it. You actually want to aspirate and debride any clear blisters and apply topical antibiotic. But you leave hemorrhagic blisters alone because this causes dermal damage to the skin. Update their tetanus. Consider antibiotics. There's not great evidence for it, but something maybe depending on the extent of the injury. They'll likely need to be admitted for further observation and workup, especially depending on what else is going on with the patient. And that is it. Further questions?
Thank you very much, Ryan, for that presentation there. And if there are any questions, please feel free to send them in, and we will do our best to answer them.
Okay, so if anyone actually wants to ask a live question using a microphone on their computer, go ahead and use the hand icon on the top left-hand corner of your control panel, and I'll be able to see that and unmute you because you currently are muted. And then you can ask the question live. So I'll give you guys a few minutes, or a few seconds at least, to see if any questions come through the chat box or live. Okay, so I do have one question here for Matt and Ryan. It was mentioned earlier that rigor mortis it was not an indicator that the patient is viable. So in the case of hypothermia, does that mean that the code 5, or obviously dead, criteria does not apply to a hypothermic patient?
Very good question. This comes down to the paramedic's judgment. I mean, if the patient is stiff, they've been out there for a week in the snowbank, then yes, I mean, that's definitely rigor mortis from absolute death. But that's going to be more of a judgment call on your part. You're not going to be faulted for bringing in a patient that you think is hypothermic and in fact has been dead for a few days. That's absolutely fine. You will not be faulted for that. So that is definitely a great question, and it is a judgment call.
Okay, thanks, Matt. No other questions coming through at this point. Actually, I do have one that just came through. Can we talk a little bit about hypothermia and drowning, and if that would change our treatment plan at all?
Thanks, Deb. It's Mike Luell here. The drowning issues come up routinely, and certainly amongst the drowning populations, which we define on the Ask MAC questions as asphyxial cardiac arrest, which are going to be run using a medical cardiac arrest medical directive. If you're considering that these patients can be hypothermic, and absolutely these patients in any time of the year in certain waters can be considered hypothermic, I would certainly apply the hypothermia directive in these patients and transport them. In terms of the therapy, though, it's the same medical directive that you'd apply. If you're treating it as a hypothermic arrest, for sure, treat that with just as per the medical directive that Ryan and Matt have described. I'm not sure if that answers the question you're looking for, but basically hypothermic drownings, for sure, follow the hypothermia medical directive if you suspect hypothermia.
Thanks, Mike. Another one has come through.
Remember, normal body temperature. Sorry, I was going to say body temperatures, remember, 37 degrees. There's not many pools or water that I know of that's 37 degrees. So.
I hope not. Another question has come through in terms of gentle handling of these patients. I guess the question is around CPR, and obviously CPR is not gentle. Do you have any comments on that?
That's a great question, and I've read the AHA guidelines multiple times in this regard, and I always find that actually humorous as how they describe that. You got to handle these patients gently, but you got to do chest compressions and then shove them in the back of an ambulance and transport them at a high rate of speed across bumpy roads, and then move them in and out of ambulances on the stretchers, and you feel free to intubate them if you have a chance if you're ALS crew while transporting. So all these things I find don't lend necessarily to the gentle transport, and I think what you're having here is the difference between what is known from a lab experiment point of view when you're looking at hypothermic hearts and the ventriculation threshold versus a real world, well, how do I get this patient to the hospital? And you're absolutely right. So if there is rough handling, sure, just be aware of the fact that rough handling of a patient, which you try to minimize all the time, can lead to ventricular fibrillation. But clearly we have a job to do, and that involves compressions and transport, and there is inherent rough handling in that, so we just try and do the best we can.
Great, thanks, Mike. No other questions have come through at this time, so I think we can call it a short webinar presentation, but a very informative one at least. I'd like to thank everyone for attending, and thank you to Matt, Mike, and Ryan for the great presentation. Just a heads up to the rest of you, our next webinar is coming up shortly, February 25th at 10 a.m. And this one's going to be surrounding midwives and EMS, and whose role is to do what, and whose patient is whose, and sort of answer a couple questions with regards to that. So thank you once again for your attention and for coming to the webinar, and hopefully we'll see you again soon in another one. Take care.